Well, hello, everyone. Thank you so much for being here today. We are really glad to have you on our webinar talking about trauma-informed approach in healthcare. My name is Mary Spetta, and I'm the Chief Impact Officer at Amira. We are a nonprofit located in New England, dedicated to providing refuge for those seeking to break free from exploitation and looking to heal in community. We serve women who have survived sexual exploitation, trafficking, and prostitution in our long term residential recovery programs, our outreach programs, and through providing education to the public on topics related to trafficking so that we can work together in community to help more women escape the cycle of exploitation. This webinar is part of our public education program, and it is the first webinar in our new Survivor Leadership series this year. Once a month, I will be joined by a survivor leader working in the anti-trafficking field to have a conversation about the gaps in service or the opportunities they see others can jump into to help in the fight to end trafficking and exploitation. This webinar will be recorded and shared on our website later this week. So if you miss anything that was said or want to share this with colleagues or friends, you can find it on our education page on www.amirainc.org. Today, we have an incredible person as our guest, and I am so thrilled that she is here. Rachel Niemiec is a family nurse practitioner and a pediatric and adult sexual assault nurse examiner with the Massachusetts Department of Public Health. Rachel is bringing a wealth of experience as a healthcare provider to us today, which is very much informed by her lived experience with the commercial sexual exploitation of children. Rachel regularly provides trainings to service providers on building trust with exploited individuals. And has some incredible insights to share with us on how a trauma-informed approach in healthcare can be transformative for patients experiencing trauma. Rachel, welcome. Thank you so much for being here today.
Thank you so much for having me, Mary.
Well, I know that I gave you a bit of an introduction, but could you give us a little bit of a more of a background on yourself and your work?
Yeah, sure. As you mentioned, I've been a family nurse practitioner in the state of Massachusetts for 8 years, a little over 8 years. Um, and before that, I did a lot of advocate work. So I was an advocate at a domestic violence and sexual assault service agency where I worked um, prior to really having a working understanding of like what trafficking meant for folks. We worked with trafficking survivors, but I think just really was starting to scratch the surface on identifying, and that went for myself as well. So I didn't really have vocabulary or words for my experience until um, probably within the last, I'd say, 10 years or so. And currently, I work for the Department of Public Health. As you mentioned, I'm a pediatric and an adult adolescent sexual assault nurse examiner. So in that role, I work primarily with youth, but I do still serve some adult survivors as well. And I work within a children's advocacy center. There are 12 of them in our state, and they each have ways to integrate medical providers into the work. And so I'm on site there to provide the medical aftercare to the kids that we serve.
Awesome. That's incredible work that you are doing, and we are so grateful for it. So today we're talking about a trauma-informed approach in healthcare. Can you tell us what is a trauma-informed approach? What is trauma-informed care, and how is that different from what we normally see in healthcare?
Yeah, so I think there are a lot of working definitions of what being trauma informed means. I happen to like the model that SAMHSA uses. So SAMHSA is the Substance Abuse and Mental Health Services Administration. I had shared with you a document that they put together that we can try to share with audience members today. But they sort of break trauma informed care up into what they call the 4 R's. So realizing, recognizing, responding, and resisting re-traumatization. I like things that are very like neatly packaged and like I can rattle off the 4 R's pretty easily. But I think trauma informed care goes a little bit deeper, of course, than just sort of like putting it into 4 R's. But just kind of quickly, the 4 R's is really respecting and realizing that everyone comes to us with their stuff, right? Everyone has experienced um, trauma in some way. And trauma is relatively subjective. So what's traumatic for me is very different than what might be traumatic for you and for, anyone in our families. And so realizing that everyone kind of comes with their stuff.
Yeah.
And that will color the way that they interact with us as service providers. It colors the way that they interact with their partners at home. So it shapes who we are as human beings. And then the recognizing piece is really being trained to recognize those signs and symptoms of trauma. So we'll talk a little bit about that later, but really making sure that service providers in particular have an understanding of what trauma might look like for a specific individual. And then the third R, responding, is really making sure that we have a system response to trauma. What I mean by that is like making sure that the person at your front desk has just as much information about how trauma might present as the nurse taking care of the patient and the physician coming in to take care of the patient. So everyone on the team has a solid understanding of how patients might present and what trauma might look like as it as it presents with different people. And also like making sure our systems are ready to be ready for survivors to interact with them. So are our environments set up to be conducive to healthy, non-confrontational, safe discussions with survivors when they're in our care? And then the resisting re-traumatization, is really avoiding practices, um, both from like a cultural perspective and a very practical perspective, that might re-traumatize someone. So for example, in my work, the kids that I examine, if they tell me that they do not want me looking at their bodies, I do not look at their bodies, right? Because my role as a safe adult is to demonstrate what it looks like to be respectful of kids' boundaries and be respectful of their bodies. So our practice is very much centered around making sure that nothing we're doing is re-traumatizing.
Mm.
So that's kind of like in a nutshell, trauma informed care. And we'll talk a little bit more about like specifics on how that works. But healthcare, you know, for lack of a better term, we tend to be more paternalistic, right? We tend to make decisions for our patients based on what we feel is best given their clinical presentation. And I'm not to say we don't know what might be helpful, but I think that there's a little bit more to that. When we're talking about coming from a trauma informed perspective, we need to understand that we're not the only expert in the room. Just
Mm.
because we have the medical training does not mean that we understand what's best for this person in front of us, and does not mean that we don't have an obligation to sort of come to a consensus around what might be best for this person, even if we feel like that might not be what's best for their care, and
Mm.
being okay with that.
Mm. Such a great explanation. And that document that Rachel referenced, we're going to send that in our follow-up email to everyone so that you have access to it. Um, there was something in there that I wanted to pull out because I think in our conversations around healthcare, we focus so much on providers. But you made a point to say that we need to make sure that everyone on the team knows what trauma might look like, because someone might walk in the front door and bear a sign of trauma or show a sign of a red flag of exploitation, and that might not present itself in the room with the provider. And I think, and when we think about healthcare, it's really got to be all of the points. Like anytime that someone interacts, the receptionist, the person at the front desk, the person doing the billing, how all of those things, how trauma can present in all of those different ways. That's so important. When we think about trauma informed care, can you tell us and give us some examples of what are some practical ways that this is put into practice?
Yeah, so I think we can think about it from like a macro level and then come down to sort of practice. So from that sort of like macro level, we're looking at our environments. So for example, when I'm talking about those like first interactions with an organization, whether that's a hospital, a clinic, when patients step into those centers, there should be something about that environment that's relatively welcoming, that's, you know, as least traumatic as it possibly can be. And I know, when we're talking about emergency departments, for example, those are like really loud and really chaotic environments, and that's going to be what it's going to be. But I'm talking about, when patients come up to the registration desk and they're just saying, "Hey, I'm here for such and such an issue." Is that person trained to be able to just sort of take a moment within the chaos and look at the individual and, maybe thank them for coming and let them know kind of what the expected wait time might be, doing some of that anticipatory guidance and just being kind about it, right? So very often when I'm talking to healthcare providers, I think sometimes we forget, like, there's magic in just being a kind human,
Mm,
right? You don't have to be the specialist in the room. You don't have to be an expert. But when you just are a kind, decent human to others, it makes a difference. And particularly when we're talking about people who are in survival mode. One of the things, and I think you and I have talked about this before, one of the things that's so incredibly amazing about survivors, particularly survivors of exploitation, is we're really good at reading the room, right? We're
mhm,
really good at reading the people that are around us because we've had to. We've had to be able to rely on those senses in order to survive in a lot of different you know incidents. And so that becomes our gift. And that means that when we walk into a room, we feel and we know pretty immediately whether that's a space that's going to be welcoming to us, safe for us, and whether people care or not. And so, when we're dismissed and when people act like they don't have the time to sort of like answer our questions or talk with us, whether or not they mean well,
mhm.
that's our first impression.
Yep.
And it can change the way we interact. So really taking a look at our policies and procedures and our environment and making sure that we're not re-triggering people.
Mhm,
And then shared decision making is something that I talk a lot about, and that's a very practical um, step that healthcare providers can take. So for example, when I'm working with adolescents, adolescents are not used to being able to make decisions about their lives just generally, right? They've got parents or guardians or whomever, usually the ones making decisions about what's happening, where they're going, where they're coming, like all of that stuff is decided for them. In healthcare, that doesn't always have to be the case. Yes, we may need a guardian or a parent to sign consent for a specific procedure, but it doesn't mean that we can't engage with that individual and find out what's important for them. So,
mm,
for example, in the work that I do, I'm having a lot of conversations with the adolescents that I serve um, around sexually transmitted infection testing, pregnancy prevention, like that kind of stuff, because that's what I do. And so, if I'm talking to an individual about their body, they're the ones, in my opinion, that get to make those decisions.
mhm,
Sometimes ultimately their parent is going to have to sign for something or going to have to be part of the decision making process. But ultimately, if that's between me and my patient. So, um, so I say kind of point blank to them, listen, I've got a whole lot of ideas about what I think might benefit you based on my training,
mhm,
but that doesn't mean that that's going to be what works for you, right? So I'd like to hear from you about what you think about, my opinions. I'm going to share with you some of the interventions that I think might be helpful. But I'm going to leave it up to you to tell me whether or not that feels like it's practical for your life,
mhm,
right? So, like, for example, I'll give a pretty concrete example. When I'm talking with kids about testing, STI testing, um, if they're not able to make it back to me for treatment, like let's say they test positive and I can't reach them because they're missing or they're on the run or they didn't give me a good working cell phone number, then I can't get in touch with them to adequately treat them.
mhm,
So I say to them, like, listen, um, if you're not going to be able to take my phone call in 2 to 3 days, what's the best way we can come up with a plan to make sure that you're getting the care that you need?
mhm,
Um, does it make sense to just do this test today, or does it make more sense for me to go ahead and treat you prophylactically? Because what I'm hearing is you're at high risk for certain things. And I'd like to prevent you from walking around with infections that you might not even know are there. And I
Mhm,
can do that. I can give you a medication today or two medications today, whatever the case may be, to help prevent this from happening. Does that feel like that's better for you than doing a test today and waiting to hear from me? Right? Because a lot of our kids, they know you're not going to get them in 2 to 3 days. You're not going to be able to pick up the phone and find them at their group home or, call their parents and try to get them. They know that that's not realistic. So when I can give them another option that fits with their lifestyle and protects their health, they're much more likely to trust me when I'm talking about other types of intervention. And I'm
mm,
stopping and I'm listening, like, what's going to work for you? Because that's what I want. I want you to be able to be successful.
mm,
I don't want to tell you this is what you need to do if you're not going to be able to do that for whatever reason. And I don't need to know all the details, but my job as your provider is to make sure that the interventions that I think are going to be great are actually going to be able to work for you.
mhm. That's really insightful, and, I'm thinking that for kids and teenagers who are experiencing the commercial sexual exploitation of children, that might be the first time that an adult has given them the opportunity to make a decision for their own body. Might be the first time that that's ever happened. And I'm wondering if you can, offer any insight. I know that we have some providers who are watching this today. Wondering if you can offer any insight on how that shared decision making process goes when you're pretty sure that the exploiter is the parent or the guardian.
Yeah, that's a good question. Um, so I never really make assumptions about the dynamic that I think is going on in front of me because I haven't lived this life and I don't know. But I do sometimes always make the assumption, right, that people come with their stuff. So there might also just be some unhealthy relationships happening for this child. And sometimes that is with their caregivers, whether it's abusive or neglectful or, there's just something unhealthy about it. So I will tell you, I have the luxury in my position because of the work that I do, that I have a whole team of providers available to me if I have concerns about safety for a kid, right? I work very closely with the Department of Children and Families. I work very closely with law enforcement, which means like if I need someone to step in and help, I usually have someone there with me. And I know that that's not true for a lot of providers, but I do have pretty frank conversations with the kids that I serve, because they usually respond much better to people who are like very direct with them,
Mhm,
versus people who kind of like dance around or think that they like can't handle tough conversations. They can handle tough conversations. Sometimes more than some of the adult patients I serve. They just want you to be clear with them. So if I have concerns about an adult that might be present with an adolescent, the first thing I'm doing is making sure that I'm separating the two. A lot of times I'll fall back on policy. So my policy is that I always meet with my patients one on one, um, just so like we can get to know each other and they can understand what I do, I can understand what they need, and that's just kind of how I do it. That's not, by the way, my policy. I just say that that's my policy, because most people don't fight us when we say like, nope, hospital policy is we separate everyone, or I'm just going to go and run a couple tests and we'll sort of loop you in when we're done, right? So I find a way to communicate with the adults that, I'm going to need some alone time with this patient, and
mhm,
that's just kind of what we do. And I don't think I've ever had anyone give pushback. People sometimes are uncomfortable with that, and you can see that in their demeanor and their behavior, but they don't usually push. So then when I have the child alone, I talk about what I observe, right? So I'm like pretty candid you know um, about what I notice. I noticed that you looked a little uncomfortable when mom, dad, whoever was sort of talking about X, Y, and Z. If I've noticed that, right? So I point out things that I notice. Um, and my job here is actually to provide care to you. So the
mhm,
most important person in this room is you. So I'd like to hear from you how I can be helpful. I can tell you some ways that I've been able to be helpful for other kids your age. And maybe you can tell me if some of that sounds like helpful to you.
mm,
Um, and then um, if they disclose that there's an unhealthy situation, obviously because they're a minor, I'm reporting that, and talking to them about what that means to report it ahead of time. But what's more important is like they get the medical care that they need, right? That's my
Mm,
job. And when we're talking about healthcare providers, at the end of the day, our job is to provide appropriate medical care. It is not to rescue kids or adults. It is not to force them into services. It is to give them options and give them medical care, right?
mhm,
We can't do everything. We have to lean on some of our community partners to sort of pick up where our role ends.
mhm,
And I take that responsibility very seriously. That's a hard boundary for me. I can't be everyone for every kid that I serve. And actually, I do more harm when I try to be that,
mm,
right? Um, so I have to assess for safety. And sometimes I have to be pretty explicit about what I mean.
mm,
So sometimes I've had situations where I've had to really come out and say, I'm feeling concerned about this dynamic that's happening. In my experience, when I see these kinds of things, it usually means there's some type of unhealthy dynamic, whether that's physical abuse, sexual abuse, exploitation. But I feel like something's up.
mhm,
And part of my job is making sure that kids are safe.
mhm,
And so if you're comfortable letting me know what's going on, I can work to try to get some help in place, right?
mm,
And that doesn't always mean that people are coming and taking you out of your home. Sometimes that means that we need to get some help in place for mom and dad. Maybe they're struggling. Maybe it's not exploitation, right? Maybe it's they're struggling with substance abuse disorder and they need some support, right?
mhm.
And so part of my job is helping to figure that out, and working with my multidisciplinary partners to figure that out. But ultimately to make sure that kids are safe.
Mm. You talked about those red flags that you see, or the things that make you question what's going on in a particular relationship dynamic. And we are often asked by healthcare providers, basically for a checklist of things to look for or things to observe. And while while checklists are okay, and they can be helpful in situations, really understanding trauma itself, the psychology behind it, the relational aspects behind it, are what inform that checklist. Can you share a little bit more about this? When you do your trainings, how do you train providers to identify individuals who may be being abused or experiencing exploitation?
Yeah, you bring up such a great point, and I think this is not specific to medical providers, but it is kind of our thing. Like we're used to algorithms and we're used to checklists, and it just makes us comfortable, right? Like I own that, because sometimes that's what helps us. That's our clinical decision making, right? Is like following algorithms. It's what we're used to. But yeah, there is no good algorithm for trauma and how that presents because everyone is a little bit different.
Mhm,
Um, and so it's not neat, it's not organized, it's ugly and it's messy. But there are some things that I think we can pick up on, and it can lead us in terms of like how we're engaging with our patients. So I tend to think about it in a few ways. So one is I look at what are the risk factors for this patient, um, and how much do I know about that? Because let's be honest, as healthcare providers, if I'm talking about like a clinic setting or an emergency room setting, we don't always have a history on a youth. We don't always know, or an adult. We don't always know like, you know, anything about their history prior to coming to us. But there's some things that we can pick up on. So, when we're getting an address for a patient, are we making sure that we're asking if that's a thing for them, or if they might struggle with housing instability? Um, when we put things out there, oftentimes that's a patient's way of judging whether or not we're ready to hear it. So if
mm,
I say to a patient, I just got to get some quick information about, about you. Can you tell me your address? And if you don't have a regular address, is that something we can help you with? Is that something that you're struggling with? A lot of my patients struggle with housing instability. It's a thing. So is that something that we can, help you with?
mm,
Instead of just saying, what's your address? because then they're going to have to figure out an address. Um, but that's not helpful, right? So I'm looking at their risk factors. Homelessness, for my youth, are they running away chronically? Do I know if they have a history of abuse? Right, we know that sexual abuse is one of the most common risk factors for exploitation. Do I know that about their history? But then I'm looking mostly at their behavior.
Mm,
Behavior to me is like, um, that's where you get so much information about a person. And I think that we want things, like I said, to be like neat and tidy and perfect, and they're just not going to be. But behavior is oftentimes my first indication that someone is struggling with something, and it's not going to tell me the whole picture, right? Because um, my patients, they might have behavior that can be indicative of a lot of different things. It can be abuse, it can be neglect, it can be they're hungry, they haven't eaten all day, so they're cranky, or they're having trouble adjusting, right? Maybe their parents are newly divorced or they're at a new school. Like there can be a lot of reasons for their behavior, but I look at their behavior first. Are they avoidant? Do they like avoid eye contact? Are they giving me really short answers to questions that probably like necessitate a longer explanation? Are they agitated? Are they hyper vigilant? So I'm looking at the big picture. And I think sometimes healthcare providers, myself included, like we can get lost in like the clinical details, right? We're looking for objective um, signs and symptoms, and we're taught to do that, but sometimes it's much bigger than that. Sometimes it's looking at really the whole picture. Like, how is this person dressed? And how are they engaging with me? Are they able to engage with me? Have they ever been able to engage with anyone in my setting? Maybe they're someone that comes in frequently. Do they have a staff member that they seem to have a good rapport with? Can I get them involved in their care? Is that a possibility? So, kind of looking big picture. Um, you know we talk a lot about sort of the history that patients give you, and I think this is a pretty definitive giveaway when patients their history doesn't really match uh, their their presentation. And what I mean by that is, I've had kids who are talking about injuries that they have on their bodies, but the story for the injury doesn't make sense, right? I know clinically the mechanism of injury to cause that uh, bruise or mark, that doesn't make sense to me, right? So that in my head, I'm tucking that away as like, something's up. And again, I don't know what's up all the time, but something's up, right? When you've had to manufacture a script
mm,
to receive care, there's something up there that I'm going to be paying special attention to. And it doesn't mean that I'm like, no, you're lying. There's no way that a bump at the door could cause a black eye. Like there's no way that that can happen. I'm not challenging my patients because that's a power dynamic thing, and you're going to lose every time.
mhm,
But it's a conversation starter for me,
mhm,
right? Um, So, and I also reflect on my own personal experience. Whenever I would engage with medical providers, that script was my lifeline. That
mhm,
script was there to keep me safe because I had no idea what was going to happen if I disclosed. So the
mm,
fear of the disclosure made me really attuned to like, just stick with the script, right?
mm,
And if they start asking you questions that you don't know how to answer, just get mean and just get quiet and they'll go away. And
mhm,
that was how I survived. So I'm very cognizant of that, and I don't want to push a patient out my door before they get the resources and information and care, most of all, from me.
mhm. And that's where the trauma informed approach is so important, is that in that experience you knew what to expect and how to react if they started throwing something at you that you didn't expect. Like you expected the clinical checklists, answer all the questions, get out the door. This person doesn't really care about me. They just want to do their job. And the trauma informed approach looks at it differently and um and kind of sees the context behind this patient, and looking for some of those gaps in the story or in the care that they have been receiving. So we've talked about how that trauma informed approach is important in building that trust with the patient and looking at the context around the circumstances that have brought the patient in front of you. So let's say we get to this point where you're pretty sure that or you have an inkling, I should say, that this person, something's not right. They're being exploited, they're being abused. Um, and here I think that providers newly kind of introduced to how to have these conversations are often looking for a 1 + 1 = 2 kind of scenario where, like, I see these red flags and that automatically means this person's being exploited. I'd love it if you could talk a bit about that, addressing that kind of idea. But also, when you get to that point of thinking something's up, what are those next steps? And how does that trauma informed approach helpful there?
Yeah, that's a great question. Because that's really the practical piece, right? And I think the number one thing that I tell folks who are interested in sort of this training, right? Like, how do I identify risk factors? How to identify indicators that someone might be being abused or exploited? But I would caution, before you do that, before you go looking for evidence, have in place a solid understanding of the resources in your area. Because here's the thing, if you start asking people what they're experiencing, you are eventually going to get someone who tells you, yep, that's happening for me. I identify with that. And if you have nothing to give them, if you don't have relationships with resources in your community, you could potentially do, unintentionally, of course, more harm than good,
Mm,
right? So now you've had a patient sit with you who's disclosed that something's happened to them. And then you're like, I really wish I had resources to give you, but I don't really know what is out there,
mhm,
right? Um, and and that's not going to feel good for you either as a provider. That's going to feel like, oh my gosh, I didn't really expect someone to like screen positive, right? We all have been doing domestic violence screening for some time, but if you don't know your agency resources or community resources and someone screens positive, what are you going to do with that,
mhm,
right? So my advice is always to sort of start, and sometimes it can feel counterintuitive, but start at the end, right? So start with compiling a list of the resources in your area. My recommendation is to always start with the survivor-led resources because there's a difference. And I'm not saying that allies and non-survivors can't do this work right, because that's not what I mean at all. I work with some phenomenal allies that I'm so grateful exist. But more often than not, survivor-led organizations or survivor-informed organizations, they just get it, and it's easier for them to adapt, particularly in a crisis situation.
mhm,
So I would identify those services in your area that are experts at this, and have them over for lunch post COVID, or like get on a Zoom and chat and learn about each other, so that when it comes time, because it will, when it comes time to refer a patient, these people by name,
mhm,
right? That warm referral process, there's nothing better. Um, so when I refer patients places, I refer them to a person that
mhm,
I've hand selected. I know them, or an organization that I work really closely with, because I know no matter what person they end up with within the organization, they're going to be fine.
mhm,
But I take that responsibility pretty seriously. I network with organizations all the time, during work hours, after work hours. That's the work, is building relationship with community organizations. Again, because I can't do it all. No
mhm,
one of us can do it all. We need partners. And so that trauma informed care extends to the relationships we're building with outside organizations.
mhm,
Um, so that when a patient does screen positive or does tell you, yeah, this resonates for me, I'm struggling, I need help, you can, without hesitating, you can say, I'm so glad that you're able to ask for help. And I'm so glad that I'm here because I can give you some resources and we can talk about this together. And like, you're super brave for being able to talk about this.
Mhm,
And, it's not my job to ask you many questions about what's going on. I don't have to know all the details in order to provide you great medical care. But now I get to give you some resources of people that I know, that I trust, um, who are gonna be great.
mhm,
And then I have those numbers, I have those pamphlets, I have, whatever it is, I have something tangible if it's safe for the patient to take that. Otherwise, I go ahead and say, you can program this number into your cell phone, you can name it whatever you want, to be inconspicuous. Um, Sometimes people will put my number like into their phone as just like nurse, because it's pretty inconspicuous. Um, but I talk with them about what's the safest way to take this information. But first you have to have the information and those relationships. And I have a few patients who, they're only safe to make phone calls when they're in, a provider space. So I'll say to them, would you like to make a call together?
mhm.
um, or I refer them to, an advocacy site who I know can do that work with them regularly. Because again, I can't be there all the time. Um, I feel like you asked something else and I totally did not answer it.
No, I think that you did because we talked about, well, we talked about the, trauma-informed approach to helping people find resources, but I think that you might have been wanting to say something about the identification process.
Yeah, yeah. So, so I like to use a tool that really highlights universal education. So I gave you a copy of I sent you the tool. It's called the PAIR tool, PEARR tool. Um, and the concept of universal education is something that was created to work with survivors of interpersonal violence. Um, but it's a great tool to use because it's kind of like for those healthcare providers that are watching, it's kind of like our universal precautions approach, right? So we always use gloves and use masks when we think we're at risk for coming in contact with bodily fluids, right? Because we're making the assumption that there might be some infection that we either want to prevent our patients from getting or prevent ourselves from spreading, right? That's the concept of universal precautions. Same kind of goes for universal education. I'm making the assumption that my patient might be able to benefit from just some education, right?
Mhm,
So that looks like if I have suspicion based on uh, red flags and indicators that something is happening for the patient in front of me, I I might say something like, um, some of the patients that I serve experience X, Y, and Z. I'm trying to come up with, I can tell you an example that happened this week. This week. I don't even know what day it is. Um, so, I'm talking with an adolescent, and there are some things that are coming up that are feeling very much like we're talking about exploitation. And so I have a tool on hand that I use that one of the children's advocacy centers that I worked with uses. It's a book that was created by GEMS in New York, and it's called A Survivor's Guide to Leaving. It's a phenomenal journal, and it was created by adolescents who had been exploited. So Survivor created, and it's written in a way that adolescents uh, can utilize. It's very user friendly, and it's like in kid talk, right? So it's perfect. Um, so when I feel like there are kids who are experiencing exploitation that I'm working with, we give them this journal, and I say something like, "This is an amazing journal that was created by kids who have experienced some really tough stuff." And they put a lot of their experiences in here and a lot of the ways that they've learned to cope, and, you know, if any of that resonates with you, I'm also going to share with you just sort of a list of resources of people who really get this, who
mhm.
do this work every single day, who are really good at like not judging the people that are in front of them, and who might be really helpful. Is that something that you feel like you might benefit from? Right. So I'm kind of normalizing the conversation. I'm
Yeah.
not saying you said this and that made me think that you're being exploited. Or I'm looking at your behavior and I'm looking at your attitude and like it screams exploitation because like no one wants to hear that about themselves, right? It's like I'm just in my head, I'm putting together all the pieces and I'm thinking, I don't really, your my ability to give you resources can't hang on your willingness to disclose to me,
Mhm.
right? I can't, that's transactional, right? And so when we're talking about exploitation, um, all of our systems, unfortunately, are really transactional. And what I mean by that is we require something of our patients in order for them to get something.
Mhm.
Tell me how that's any different than what it feels like to be exploited.
Mm, you're so
It's
right.
not. It's not. So I can't be someone who's forcing or creating an environment where a kid or an adult has to do something for me in order to get something from me. But no, I can't be that. So I just sort of like put everything together in my head. I don't need to point it all out. And I'm just like, hey, some of the kids that I work with have experienced some tough stuff. And this is actually a really great resource. Feel free to look through it. You can take it, you can leave it, totally up to you. But maybe just, take a few minutes, sit through, look through. If you have questions, I'm here. If not, like, that's cool too,
Mhm.
you know? Because what we know about exploitation, what we know about domestic violence, what we know about most forms of interpersonal violence is it takes someone a number of times to feel ready to exit.
Mhm.
So this might be, time 3 that someone's trying to engage with this patient, or it could be the last time and they could be really ready and really just need, that encouragement.
Mhm.
And I can't take responsibility for their trajectory. I can just hope that I'm there when they're ready with
Mm,
resources and ready to help.
mhm.
So so that's kind of how I uh, manage that. I think we could talk all day about like the specifics for healthcare providers on like documenting that and all that kind of stuff. And that's important, especially when we're talking about minors. And the reporting process is important, especially when we're talking about minors. We have to report this. Um, but there's a way to do all of that and also help the person in front of you and find out what is going to be helpful, and conversely what is not going to be helpful, right?
Mhm.
So it's not helpful for me to tell a kid or an adult you're a victim of human
Mhm.
trafficking. Like, that's big,
Yep.
right? It's helpful though if I'm like, here are some experiences that other people have had,
Mhm.
and if you find yourself connecting with that, if you find that resonating with you, here's an opportunity to just learn a little bit more about that.
Mhm.
That universal education is huge because it allows the survivor to take the time to figure out what is happening for them. It
Mhm.
is not on us to tell us what their experience is, to quantify it, to name it. Um, that's not always helpful.
Mhm.
And sometimes it can be harmful. So it is our responsibility to just give them some education.
Mhm.
Like if they're talking about a specific partner that they have, let's say they're giving me some examples around like how they're being mistreated. I don't have to call their partner a bad word. I don't have to say that they're a bad person. That's not helpful. But I can say
Yep.
something like, that must feel really tough. Like, you're explaining to me
Mhm.
how it's difficult for you to negotiate not having, sex with your partner, or, you're talking to me about how you're not able to choose the clothes that you want to wear,
Mhm.
you know? That can feel tough sometimes, I imagine.
Yeah.
All right. But then I'm also being respectful and like, well, what are some good things about this person?
Mhm.
Because I care about the totality of their life, not just their exploitation or just their sexual abuse. So I'm genuinely curious about the person in front of me. And I genuinely want to give them some education around what's healthy and what's not healthy if they're open to hearing it. And if they're not, then they're not. And
Yep.
it's not my job to coerce them into learning or into exiting.
Mhm. And that's a great way to bring the awareness of the things that come with trauma, like trauma bonds, where that they might be very attached to whoever the person is who could be abusing or exploiting them, and not ready to identify, not ready to have their whole life and their world blown up. Um, that's incredibly insightful. For everyone watching, we're gonna hop into a Q&A time. So if you have a question for Rachel, you can drop it in the Q&A box there. And as people are kind of putting thoughts together, Rachel, I wonder if you can share a little bit, just briefly, about some of the trainings that you offer. We're gonna put Rachel's contact information in the chat for anyone who's interested in getting a more in-depth training from Rachel on this subject.
Yeah, so our program does a specific training that's very specific to medical providers, particularly those that work in emergency departments. So we've developed that, and I share within that training a lot of my own personal experience of interacting with medical providers or providers generally, um, and sort of how that has shaped the way that I operate as a provider. Um, and then I'm a fan of also like just like spreading the love and allowing people to interact with other particularly survivor-led organizations. So I know at Amira, you guys do phenomenal training. So I would encourage people to check out, your website and look at the webinars that you're going to be doing and have done. I would encourage folks who work with youth to connect with My Life, My Choice in Boston. They do phenomenal trainings. They do like a 101 and they do like an advanced clinical training for providers. So there's a lot out there. I think there's also a lot of misinformation out there. So just be critical in thinking about the information that you're consuming, really looking at it and thinking like, does this align with the things that I'm hearing from survivors in this movement? Um, yeah, and so I think there's a lot out there. So people are welcome to reach out to me, and I'm happy to share resources. We are lucky in this area. We have like a wealth of resources in Massachusetts. We still have a ways to go, but we have a lot of providers and a lot of survivor leaders that I would point you all to.
Mhm. That's great. And we did drop the Rachel's email address in the chat for anyone who's interested in reaching out to her. We do have a question about a current list of resources available. I'm not sure what region this person is in. If uh, whoever asked this question, if you could let us know what region you're in, but let's say it's New England, because resources are different everywhere. Do you have a current list, Rachel, that you know of that maybe you have or is on the website of resources available?
Yeah, so you might not like my answer. I have created and cultivated lists of resources, but they're very like specific to what it is you're looking for, right? So, um, if you're looking for services for youth or adults, I can give you what I have. If you want to contact me, I see that Mary put my email in the chat. So please feel free to reach out, and if you're open to giving me some specifics around what types of resources you're looking for. We are also going to share that pair tool that I talked about, which I think is a really practical tool in terms of a resource for providers who are working with any type of patient. Universal education is just like a solid place to come from with anyone that you're working with.
Yeah. We have a question about do you work with seniors in any capacity?
So I don't currently, but many organizations do. And so I can definitely connect you to the resources that provide services to seniors. Um, I know I know we have state organizations that provide care to seniors as well. So again, I might ask like a little bit more specific, what kinds of services or things like that. But yeah, there are folks who provide services to elders.
Okay, great. Um, we have a question about a kind of balance. How do you find balance after after being exposed to different types of trauma over and over again in your practice?
Yeah, that's such a good question. Um, and I think that that's part of being trauma informed is making sure that we're also resisting that re-traumatization of ourselves, right? Particularly those of us that have lived experience. Um, so for me, that's a practice. That's an everyday thing that I do. I have like certain things that I do every day that ground me, that protect my energy, that make sure that I take care of myself because when we struggle with burnout, which happens, then we're no good to anybody, right? So I'm also a mom. I'm also a wife. I'm like a lot of different roles. I'm a student. So I need to be okay in order to function. Um, so I am very I'm very good at sort of like being in touch with myself, understanding when I need a break, and not feeling guilty for taking the space to have that break,
Mm,
because I need to be okay in order to do this work. We all do.
mhm,
So yeah, so I call it a practice because it's something that I have to engage in every day, whether it's going for walks, spending time with my kids, um, reading good books or watching TV that is not violent or graphic, and talking with coworkers and debriefing and doing all those things.
mhm. We have a question about telehealth in the pandemic. Have you had to change any of your trauma informed practices by not being able to treat a person in person?
Yeah, I'll tell you that this is something I struggle with, both as a survivor and as a provider. And the reason is I rely on contact, like in-person contact. Um, I I that energy exchange is important to me. And when we're virtual, it's really hard to get a read on like how people are doing. I also have to be very careful to not sort of uproot trauma and then like let someone just go off the screen and back to their life when they may not have services in place or someone to check in on them. So yeah, it can be a little bit more difficult. I am not routinely providing care via telehealth. I've been doing a lot of care in person.
Mm,
Um, so so it's not something that I have to struggle with a lot. But if that were the case, I've had a couple of interactions with youth, particularly youth who are in group homes via telehealth, and I'm always making sure that I'm checking in with their clinicians. I have permission to check in with their clinicians so that there's someone in place after we're done working together, to check in with that child,
mhm,
um, so they're not just kind of like hanging out there.
mm,
And I'm also I'm not doing therapy with kids, of course, so we're not really digging into a whole lot, but yeah, making sure that people have the resources when you're not there is really important.
yeah. Here's a question about culture. How have you integrated cultural competence into the care of your practice? Any specific interventions to improve this?
Yeah, so I was talking about this the other day with some folks in my program. Um, it was a very simple example, but I'll share it anyways. So I've had a couple kids during this pandemic um, who have gone missing, or have become absent from care. Um, and they're kids, right? So like one of their complaints about like their group home facilities or wherever they're placed is like, well, they never get the food that I like, right? Because in my culture, I eat such and such. Like these are the things that I like. They're comfort foods to me. And they're like just not. they don't want to accommodate me. They don't want to get me what I want, right? And so like my job as an advocate for them is to like reach out to program staff and be like, listen, you know, is this really a thing? Is this something that you guys can't do? Because if it is, then we'll talk about that. But, you know, I think probably there's a way for us to make sure that we're providing uh, foods that are representative of where these kids come from. It's such a big thing. Food is such a big thing. Um, you know, that like, can we not try to make things a little bit more comfortable for the kids that we're serving, right? That's just one small example, but it's huge to some kids. And it's literally sometimes the reason why they're like, I'm not going back there. Their food is gross, right? And I'm like, you know, so, um, but also like from a larger perspective, thinking culturally, you know, I have a lot of families that we work with that um, certain practices, parenting practices, for example, are acceptable in their culture. And they may not be acceptable here. And so we have to really come from a place of understanding. Like, it's not that parents want to be harmful, I don't think. It's not that they want to hurt their kids or they want to break the law. Sometimes it's just, have we thought about offering alternatives? Have we thought about working with them to maybe minimize stress levels? Like, what's going on for this family, right? Instead of just calling people bad parents or saying, you know, you're hurting your kid, that's not super helpful. So, I like to just try to like figure out where people are coming from, meeting them where they're at and helping to maybe give skills that aren't there, right? Trauma is generational. Um, and abuse cycles tend to be generational as well. So, how can we help to break those cycles and provide some education and provide some interventions that
Mhm.
are beneficial for the entire family unit?
Mm, that's so good. Well, that is all the time that we have today. I definitely encourage you, if you're interested in getting training on this for your workplace, please reach out to Rachel. A really incredible training that will be so beneficial to you and your colleagues. Rachel, it was truly wonderful to have you here today. We are so grateful for you and the work that you do in the world and your willingness to share your wisdom with us.
Thank you so much for having me. I always love chatting.
For everyone attending, if you have questions about today's webinar or if you want to know how to get in touch with Rachel if you're having trouble, then you can email us at info@amirainc.org. You can also sign up for our newsletter to get information about upcoming webinars in this series at www.amirainc.org. We hope today's conversation was helpful and inspiring. Thank you all for joining us.
Thank you.